Medurstand Understanding Medicine.
I'm Professor Aziz Rehman from Medurstand-Understanding Medicine. Today we're going to talk about a condition which is potentially very serious and unfortunately fairly common also. It is chronic kidney disease. This is the new nomenclature, and in the previous literature it used to be called chronic renal failure. But since it has got very broad spectrum, some patient may have chronic kidney disease but may not have any symptoms, so it would be unfair to call them having a renal failure. So that is why the new term chronic kidney disease. And I have divided this lecture into two because the topic was very vast. I tried to condense it, but still I would like to cover it in two lectures. This first one will talk about the etiology, the clinical features and the diagnosis, and the remaining part, the prognosis and the treatment and the complication, we'll talk about in the next lecture. I strongly request you that after listening to this video, please wait for the next one also to complete the module. In introduction, very common, especially the milder forms. Now, when I will talk about the definition, you will realize that there are people who may not have any symptoms, and if you include them also, it is fairly common condition. And it is actually a result of many other diseases, like many patients, diabetes, hypertension, they will end up having chronic kidney disease. So that's why it is common. And it carries very high morbidity and mortality. Very unfortunately, very demanding disease, very expensive disease, and a lot of complications when the disease is advanced. But a very important thing is, in many situations, it is preventable. I think we should never let this opportunity go. If something is preventable, we must try to prevent it. And if we do not do what is required to prevent it, that means we have not done our job well. So I think patient, the physician, and the family have to play their roles to prevent CKD in those patients who are vulnerable to develop this. The definition of CKD, we need to fulfill one or two of total of three conditions. And those conditions must be there for at least 3 months to be called chronic, because less than that comes under the heading of acute. So what are those three conditions? First of all, abnormal amount of proteins excreted in the urine, typically albumin. Normally very small amount of albumin is excreted in the urine, less than 30 milligram, and this cannot be detected with the ordinary test. But if you use specialized method of checking this albumin in the urine, and you can detect as low as 30 milligram, and it is typically expressed as milligram of albumin per gram of creatinine. And this is usually done on the morning sample. Previously, we used to do 24-hour urinary collection, and sometimes spot urine was also done, but they were all subject to either the 24 hours urine collection was very cumbersome, and the spot urine was actually subject to the variation of concentration. So if you measure morning sample albumin and also creatinine and express it as albumin in milligrams per grams of creatinine, this would give you very accurate reading, and any figure more than 30 is abnormal. So there would be microalbuminuria, this will progress to frank albuminuria, but more than 30 is clearly abnormal. And if somebody has this, typically we repeat it after 3 months, and if that persists, that qualifies for chronic kidney disease label. And second is reduction in eGFR. We calculate it from creatinine and also patient weight, patient age, patient gender, patient ethnicity. Various formulae are available. GFR is clearly better than creatinine, so you should determine the GFR. but just little reduction in GFR is not enough to label somebody as a case of chronic kidney disease, because there is age appropriate decline in GFR also. So in those patients, you need to have some additional abnormality to label them as a case of CKD. And third one is any marker of kidney disease. Now, patient may still have GFR within normal range, or ACR may also be still within the normal range, but there is some other indicator of chronic kidney disease. For example, a urinary sediment. If you examine urine, if there are proteins, the cells and the cast, that would indicate the chronic kidney disease. And if on ultrasound there is change in echogenicity of the kidneys are shrunken, that would also indicate chronic kidney disease. So I think depending upon the case, one or two conditions, if are present for the last 3 months, you could label them as a case of chronic kidney disease. Etiology, glomerular nephritis I have listed as the first possibility because it is a primary disease of kidney, but in my opinion that is not the commonest cause. Autoimmune disease, again a systemic disease like SLE, kidney could be involved, again not that common, but amyloidosis, again rare. I think the commonest cause, at least as far as I'm concerned, I'm an internist, I practice medicine, I see a lot of patients with diabetes and hypertension. So in my opinion, it is the diabetes and hypertension which are the commonest causes of chronic kidney disease. And very surely these conditions, if managed properly, you can prevent chronic kidney disease. So here I think our options of preventing chronic kidney diseases are less, but in diabetes and hypertension, with proper control of these conditions and with proper medication, you can actually prevent the complication of CKD. Then many drugs, most importantly non-steroidal anti-inflammatory drugs. Typically non-steroidal anti-inflammatory drugs are prescribed for a short duration, but some people they have to take it for long term, so they are likely to develop CKD. Then many others actually. So kidneys are one of the very vulnerable organs in the body, because whatever we eat, all the metabolites in the body, mostly they are excreted through the kidneys. So kidneys are extremely vulnerable to the harmful effect of these toxic substances. Now, this is the classification, you could say classification or different stages. Actually, these are different stages. Naturally, patient would pass through these stages. Now, not that patient would straight away develop CKD5. Of course, he or she would pass through these stages. He might be diagnosed at this stage. The previous stages may be missed, but typically patient will pass through these stages, and typically with proper control of the causative illness can slow down or halt or slow down the further progression. Now, it is based on GFR, which is calculated by the formula. That's what we call it, estimated GFR. It is expressed in milliliters per minute per 1.73 meter square area. Now 1.73 meter square area means to an average built person, so that for every person you don't have to make correction for the weight. So if somebody has a GFR of more than 90, but this is actually normal, GFR of more than 90 is normal, but there is something, that something could be albuminuria, or something could be any other manifestation of chronic kidney disease, but as far as GFR is concerned, it is within the normal range. And in CKD2, again, GFR between 60 to 89, this is stage 2. Again, most probably this patient would not have any symptom. Some additional thing would be required to label him as a case of chronic kidney disease, because in elderly people, GFR can be normally within this range. So just having GFR in this range would probably not be enough to label somebody as a case of CKD2 unless there is additional something in the form of albuminuria or something. CKD3, this is definitely abnormal range, GFR between 30 and 59, and then there are some authorities, they classify CKD3 into two groups actually, CKD3A and CKD3B, so that will be midway. CKD4 is GFR between 15 and 29. These patients are very likely to be symptomatic. And CKD5 is, of course, GFR less than 15. That means kidneys function are extremely low, or anybody who has GFR of whatever, but he is on dialysis, that will also be classified as a case of CKD5. So this is the classification. We hope that our patient, they stay within the first and second category and they don't progress to stage 3, 4 and 5. But of course, if the underlying disease is not controllable or cannot be controlled, then patient would go to this stage, and these patients would require either dialysis or renal transplant. Some classifications use different criteria. They would add the word T. T would mean that the patient has got kidney transplant. They might add D. D would mean that they are on dialysis. So this is the basic concept of staging. Pathophysiology, of course, there is damage to the nephron. The nephron consists of vessels. Nephron consists of a glomerular cup, Bowman's capsule, and nephron consists of tubules. So there is, I think that primarily it is the damage to the glomerulus. Glomerulus basement membrane is damaged, and this is usually progressive, especially if the underlying disease is not controlled. So there is progressive drop in the number of nephrons, and those which are still alive, they undergo sclerosis because of additional pressure of excretion on them. So this would lead to excretory dysfunction. All substances which are excreted by the kidney, like creatinine, urea, urea nitrogen, sulfates, and all the stuff which is excreted by the kidney, they would be retained. Potassium, they would be retained. So that is one manifestation. The second one is, kidney is also a hormone producing organ. It is an actually endocrine tissue also. So it produces erythropoietin, it activates vitamin D. So some manifestation would be through hormonal dysfunction. And this would then cause systemic manifestation. There is no organ in the body which can work properly without a properly functioning kidney. So when patient goes to the advanced stage, you can expect any symptom, any sign, any laboratory abnormality coming from any part of the body. So wide spectrum of disease. So natural history, so patient has got, say at a certain time, at the time of diagnosis, so you have made a diagnosis at a certain stage like CKD1 or 2 or 3 or whatever, then it could follow one of the three courses. Very unfortunately, mostly there would be progressive decline in glomerular function. The decline may be slower or may be faster depending upon the control and also depending upon additional factors. For example, if this patient develops severe prolonged dehydration, the GFR may drop more rapidly. If this patient develops recurrent urinary tract infection, again it may fall very fast. And if this patient develops some other damage due to some toxin, non-steroidal anti-inflammatory drugs, so this decline may be faster. But what we hope is that with proper control of the underlying disease, diabetes or hypertension or other condition, we hope to maintain the GFR at that level. So we want to actually halt the disease or slow down the progression. But in an ideal world, we should aim for the recovery. Some patient may actually recover, very few if the underlying disease is controllable. But in my experience, this is the commonest outcome. This is the one we hope for, the wish for, and this is actually very rare and we can only dream for this. Now, again, I think this is another expression of the same concept. The prognosis is based on two main things. One, the GFR. Of course, as the GFR goes down, the prognosis becomes poorer, right? And similarly, the amount of albumin excreted in the urine. Actually, some authorities, they have divided albuminuria into three stages: stage 1, stage 2, stage 3. Like we have GFR stages 1 to 5. They have also classified albuminuria into stage 1, 2, 3. So as albuminuria increases and as GFR reduces, the prognosis becomes worse and worse. And ultimately, the patient ends up in having what we call end-stage renal disease, or somebody might like to call it end-stage kidney disease. And this is typically CKD5, eGFR less than 15. Somebody might still survive without dialysis up when GFR comes to 10, but less than 10 definitely would require dialysis. And volume depletion, infection, and any nephrotoxic drugs can make it faster. So prognosis varies. In some it may be good, in some it may be bad. Much is in your hands actually. So very important, if you educate your patient well and if you treat them well, this can definitely be altered. The natural course of chronic kidney disease can be altered favorably. The spectrum based on clinical features, extremely wide spectrum. People with CKD1 and 2 and some CKD3 also may not have any symptoms at all. None whatsoever. They may be discovered on routine screening. And people with CKD4 and 5 are most likely to be very miserable. They may have dyspnea, they may have pallor, they may have edema, they may be having bone disease, they may be suffering from anemia and many other things. And these patients are very sick. And in between, of course, you may have all grades and shades. Now, let me present to you the clinical features. As I said, it is extremely wide spectrum. It is not possible for me to cover all the symptoms, but I'm going to cover the main ones. I think all clinical features can be divided into these 5 categories. Fluid and electrolytes, which is the main function of the kidneys, then hematological because of erythropoietin, calcium and bone because of vitamin D, and cardiovascular because patients with kidney disease, they are more prone to develop atherosclerotic cardiovascular disease, and many others. So let me go through them one by one, but I'll try to be as brief as possible. First of all, fluid and electrolytes. There may be oliguria, there may be reduction in urine output, and patient may have water retention. And this water retention may present in the form of edema, or maybe in the form of ascites, maybe in the form of scrotal edema, or pleural effusions, or even brain edema. Hyperkalemia, because potassium is excreted by the kidneys. Initially, there may be some compensation, and despite having chronic kidney disease, patient may still maintain normal potassium, but ultimately it will rise. And then again, we have various stages, and high potassium would mean that patient would require an urgent dialysis. Hypermagnesemia. Hypermagnesemia is important because this promotes bone disease and because it stimulates hyperparathyroidism. And then metabolic acidosis. You know, many acids are excreted by the kidney, and bicarb is also regulated by the kidney. So patients with kidney disease are likely to develop metabolic acidosis, and this could present with Kussmaul's breathing, which is acidotic breathing, and pH would be acidic, bicarb would be low, and anion gap would be wide. There may be another kidney disease where anion gap may be normal, but in the typical form of chronic kidney disease, in advanced disease, CKD 4 and 5, you can have these complications. Now let's talk about the hematological manifestation. In hematological manifestation, first thing is anemia. Anemia could be due to several reasons. The commonest reason is a lack of erythropoietin. Your bone marrow may be normal structurally, and you may have all the ingredients required to make blood, like you have iron, you have folic acid, you have vitamin B12, but still your bone is not making enough, bone marrow is not making enough blood, and this would result in normochromic normocytic anemia. Remember, these patients may have additional deficiencies also, and they may also have the component of anemia of chronic disease. So there could be multiple factors contributing to anemia, but I think the most important is erythropoietin. Thrombocytopenia is also possible, and then leukopenia is also possible because there is overall bone marrow suppression. There is very hostile milieu in the bone marrow because of retention of various toxic substances and the production of all cells, including other body cells like sperms and epithelial cells. The production of these cells is reduced, and you may have thrombocytopenia and leukopenia, but the commonest one is anemia. Now let's talk about calcium and bone. As I told you, vitamin D, what we take in the form of supplements, or what we take in the form of diet, or the vitamin D which is made within our body when we expose ourselves to sun. So that vitamin D is not active. It has to pass through two activation processes. One is in the liver, the second one is in the kidney. So if kidney mass is reduced, the activation of vitamin D would be affected, and effective vitamin D will not be there. So there would be a manifestation of vitamin D deficiency. So this could lead to hypocalcemia and then hyperphosphatemia, and then these two could lead to hypermagnesemia also. Now hypermagnesemia will further complicate the effects of hypocalcemia and hyperphosphatemia. Both hypocalcemia and hyperphosphatemia, both of them, they cause secondary hyperparathyroidism. Parathyroid increases its secretion to cover the deficiency of calcium, and hypermagnesemia would further increase the effect of parathormone. So this might correct serum calcium. This is, I think, the physiological intention, but this would lead to progressive bone loss. So these patients would end up developing what is called renal osteoarthropathy. Secondary hyperparathyroidism and then bone demineralization. I think all this will end up, luckily these days this is happening less and less commonly because effective treatment of chronic kidney disease is now available. But in last decades, I know many patients would have these things, and because dialysis was not available to everyone. Now the last one, the second last one is the cardiovascular. You know, cardiovascular, first of all, hypertension. I have a separate lecture on renal hypertension. If you've not watched that video, please watch that video also. So any kidney disease could lead to hypertension, and hypertension could cause kidney damage. So there is a vicious cycle. Hypertension is the commonest manifestation of chronic kidney disease, but increased risk of atherosclerotic cardiovascular disease. This is very important. There may be associated dyslipidemia. These patients may be smoker also. So people with CKD are undoubtedly at a much higher risk of developing ischemic heart disease and CVAs. So we consider them as high risk patients. We treat their blood pressure, their diabetes, their dyslipidemia, their other risk factors more aggressively to prevent atherosclerotic cardiovascular disease. Heart failure is also possible if they have underlying coronary artery disease, and retention of sodium and water will increase the extracellular fluid, and that might actually push these patients into heart failure. Then pulmonary edema, again water retention, pulmonary edema is also one of the manifestations of heart failure. So all these atherosclerotic cardiovascular diseases are common in patients with CKD. Pericardial effusion is also. I think the mechanism of this is retention of some toxic substances, because there may be pleuritis, there may be pleural effusion, there may be pericarditis, there may be inflammation of other serosal surfaces, and there may be pruritus also. Then others, there is actually a whole long list of other manifestation. GIT related, there will be anorexia, there may be vomiting, there may be dyspepsia, and they may develop malnutrition. CNS related, any level of altered state of consciousness, from just little drowsiness to frank coma and seizures and those typical tremors, flapping tremors, all these are present in patient, can be seen in patient with advanced kidney disease. In the respiratory system, there may be pleural effusion, there may be respiratory failure. In skin, there is usually pallor because of lack of hemoglobin, and there is pruritus, and there may be what is called uremic frost. Only when creatinine, urea is very high, there may be a typical frosty look of the skin, and that is called uremic frost. Luckily, these things are becoming less and less common because we have no effective treatment of this serious disease. In bone and joints, there is renal osteoarthropathy. It's very hard to define what is renal osteoarthropathy. Actually, there are multiple factors. Vitamin D deficiency, hypocalcemia, hyperphosphatemia, hyperparathyroidism, malnutrition, chronic acidosis. So all these things, they lead to bone damage and joint disease, and this is in a vague term called renal osteoarthropathy. So these patients, they're more prone to develop fractures and other joint problems and disease, the bone problems. Then reproductive system, of course, this is one of those systems which requires very physiological situation, the infertility both in men and women, and erectile dysfunction in men. So these are again common manifestations of chronic kidney disease. So this was all in the first part. I hope I was able to give you a brief account of the definition, the stages, and the clinical manifestation. And I made a disclaimer that it is not possible to cover the entire spectrum of clinical manifestation. So I gave you a summary. You can expand on that by reading more. And I would be very happy if you leave a question here, and I'd like to answer. Those who want to learn more, they can post their question here. So to sum up, common disease with high morbidity and mortality, especially CKD 4 and 5. Various etiologies, and some types of CKD are preventable, like diabetes related CKD, hypertension related CKD are preventable. How? I'm going to talk in the next lecture. Wide range of symptomatology, somebody who is asymptomatic to the other extreme, somebody who is very sick. So I think there's a whole range of symptomatology, and diagnosis is very simple. All you need to do is to check their creatinine, have their urine test, and estimate GFR from a formula which is available online. So I hope to see you in my next lecture, which is going to cover the remaining part of CKD. This has been Professor Aziz Rehman from Medurstand-Understanding Medicine.